Okay, Section 1, Acute Urinary Retention, Initial Management, and Pathways. Now for this classic presentation, immediate decompression is your absolute first priority, right? Let's see how this builds into a really clear 4-step clinical algorithm for your initial ER and definitive management. Step 1, always your ABCs and analgesia. Seriously, don't forget the pain control. This is an incredibly uncomfortable condition for the patient. Step 2 is the actual intervention. Immediate urethral catheterization using a Foley. If that's tricky, you get an experienced clinician to try a Coude catheter. But, and this is crucial, if you suspect a urethral injury or the catheter fails, you pivot immediately to a suprapubic cystostomy. Okay, step 3 is monitoring. You've got to watch closely for post-obstructive diuresis once those floodgates open. And finally, step 4 targets the root cause. So if it's BPH, we're looking at alpha blockers or TURP. Stricture, endoscopic treatment, or urethroplasty. A stone gets definitive stone management, and a neurogenic bladder is going to require clean intermittent catheterization. Looking at the required investigations right alongside the strict surgical indications, precision is just key here. On the left, for your workup, you need a CBC, urinalysis with or without culture, and your renal function tests. You'll get your ultrasound KUB, but, and make sure you remember this, only after decompression. What about PSA testing? Only after the acute retention has fully resolved, otherwise you're going to get a falsely elevated reading and chase your tail. Now, on the right, surgery is indicated when medical therapy fails, or if the patient comes back with recurrent retention, recurrent UTIs, bladder stones, renal impairment strictly due to the obstruction, or recurrent gross hematuria caused by BPH. Let's lock in these high-yield pearls from this box. The absolute most crucial point, you never, ever force a urethral catheter. No exceptions. If you suspect an injury, you must get a retrograde urethrogram before even attempting catheterization. Also, rapid, complete bladder drainage, it's perfectly safe, but you must always watch for that post-obstructive diuresis we talked about. And just keep in mind, BPH is the most common culprit you'll see in elderly men. Moving on to Section 2, Testicular Torsion Emergency. Time is tissue. In these cases, your clinical suspicion alone dictates the timeline. As they say, time is tissue. This step-by-step pathway highlights that you've got to prep for emergency exploration immediately. Step 1, ABCs, analgesia, keep the patient NPO, and get an immediate urology consult online. Step 2 is huge. Do not delay surgery to get a Doppler ultrasound if your clinical suspicion is high. You are literally racing against the clock here. Step 3 is emergency scrotal exploration and detorsion to get that blood flowing again. And finally, step 4 includes a bilateral orchidopexy to secure both testes or an orchidocexy if, unfortunately, the affected tissue is already non-viable. The protocol takes a really strict stance on investigations here. As you can see, surgery is indicated for any suspected torsion. The diagnosis is primarily clinical. You only order that Doppler ultrasound if uncertainty exists and, this is a massive and, if getting it will not delay the surgery. Okay, let's lock in these pearls. Remember that a missing cremasteric reflex is your absolute most reliable clinical sign, and the clock is loudly ticking on that strict 6-hour salvage window. A high-riding, horizontal testis is the classic presentation, and it's often accompanied by nausea and vomiting. To reiterate, you always perform a bilateral orchidopexy to prevent future torsion on the other side. And say it with me, a Doppler must never delay your path to the operating room. All right, Section 3, urethral and bladder injuries, trauma differentiation. Down in the trauma bay, we have to differentiate between urethral and bladder injuries because they require completely different catheterization approaches. Comparing the two, notice the stark contrast here. For a suspected urethral injury, your initial ER management mandates avoiding blind catheterization at all costs. If you need urinary diversion, you use a suprapubic catheter. Your gold standard investigation here is the retrograde urethrogram, or RUG. Conversely, for a bladder injury, you place a Foley catheter, but only after you've successfully excluded a urethral injury. And for bladder trauma, your investigation of choice shifts over to CT cystography. Definitive management hinges strictly on the injury type. Check out this table. If you have an intraperitoneal bladder rupture, that means mandatory surgical repair. Every single time. But if it's an uncomplicated extraperitoneal bladder rupture, you can usually manage it with simple catheter drainage. Now looking at the urethra, partial tears are also managed with catheter drainage, while complete disruptions are going to require delayed urethroplasty. You're heading to surgery for complete urethral disruptions, complex injuries, or if those conservative treatments just fail. These combined pearls are pure gold for exam recall and real-world clinical practice. specifically when noting the anatomical clues. For urethral injuries, blood at the meatus is your hallmark warning sign. A straddle injury? That usually points to anterior urethral damage, whereas a pelvic fracture or finding a high-riding prostate points to posterior injury. For bladder injuries, a pelvic fracture is the most common cause, and gross hematuria is the most common presentation. Oh, and note this anatomical fact. The dome of the bladder is the most common site for an intraperitoneal rupture. Section 4. Renal Trauma Protocol. Hemodynamic Decision-Making. For renal trauma, the entire management tree hinges completely on one single factor, the hemodynamic stability of the patient. In our ER sequence here, stabilization comes first. Step 1 is following your ATLS protocols, assessing hemodynamics and pumping IV fluids or blood. Step 2 is placing a catheter to monitor urine output, assuming there's no urethral contraindication, obviously. Step 3 introduces the investigation of choice, a contrast-enhanced CT with a delayed phase. That delayed phase is absolutely critical for catching collecting system injuries. But remember, you only put a patient in the CT scanner if they are stable. You're also running a FAST exam, urinalysis, CBC, and renal function tests. Notice how the management pathways plot out cleanly, based entirely on stability. If the patient is completely stable, management is conservative. If they're stable but have an ongoing bleed, they go to angioembolization. But if they're hemodynamically unstable, straight to the OR. The firm indications for surgery include persistent instability, an expanding retroperitoneal hematoma, a renal pedicle avulsion, or if they just keep bleeding even after you've tried embolization. The big takeaway here is organ preservation. Because most blunt renal injuries can be safely managed conservatively, hemodynamics pretty much rule all your decisions. Remember to get those delayed CT images to spot collecting system leaks, and always strive to preserve the kidney whenever clinically possible. Finally, Section 5. Pyonephrosis and urosepsis, the infection spectrum. These are severe conditions where minutes equal nephrons and ultimately lives. While both require aggressive fluids and cultures, notice the subtle but absolutely critical differences in priority here. For pyonephrosis, which is an obstructed infected kidney, the emphasis on immediate urinary drainage and urgent urology referral right alongside your antibiotics. For urosepsis, though, you are launching a full systemic sepsis protocol. That means IV crystalloids, cultures, and broad-spectrum IV antibiotics strictly within 1 single hour. You're adding oxygen, vasopressors if they're fluid refractory, and focusing really heavily on source control. It's so crucial to align these diagnostic gold standards. For pyonephrosis, your initial test is an ultrasound KUB, but the gold standard in a stable patient is a non-contrast CT KUB. For definitive management, you place a DJ stent or a percutaneous nephrostomy tube, a PCN. Now for urosepsis, right next to your standard labs, you absolutely must monitor serum lactate. Management focuses on relieving the obstruction and transitioning to culture-guided antibiotics, which often requires ICU care. For pyonephrosis, you escalate to surgery for failed drainage or a non-functioning, completely destroyed kidney. I really cannot stress these final high-yield pearls enough, guys. Pyonephrosis is a true urological emergency because antibiotics alone will utterly fail against a closed-space infection. You must drain the system first and deal with the stone later. Any delay directly increases mortality. In urosepsis, that obstructed infected kidney is the most common surgical cause, meaning source control is just as vital as your antibiotics. Never delay drainage. And keep an eye on that elevated lactate. It's a direct indicator of poor tissue perfusion.
All right, Section 1, the 5-star emergency. We are talking about fornia gangrene.
Now, for this emergency, you've literally got to act fast. Aggressive, simultaneous action is required the second a patient rolls in. You initiate ABCs, pump aggressive IV fluids, and hang those broad-spectrum IV antibiotics immediately. You also need to correct that hyperglycemia right before making an urgent surgical referral. Meanwhile, your diagnostic workup has some pretty strict criteria. Order your CBC, CRP, glucose, renal panels, and blood cultures right away. But a CT scan? Listen, only order a CT if the diagnosis is completely uncertain and, this is crucial, the patient is actually stable.
When we shift over to definitive management, think of it as a fast-paced algorithmic flow. Step 1 is emergency. Aggressive surgical debridement. You just cannot wait. Step 2 acknowledges that honestly, this is rarely a one-and-done procedure, right? Repeat debridements are frequently required, alongside a vac dressing and meticulous wound care. Finally, Step 3, which only happens after the infection fully resolves, involves a skin graft or flap to reconstruct the defect.
So, the absolute crucial mandate here. all patients require urgent debridement. For your one-line recalls, lock this in. Fournier gangrene is necrotizing fasciitis of the perineum, and diabetes is the most common risk factor, which, by the way, is exactly why correcting hyperglycemia is step 1. But most importantly, do not delay surgery for a CT scan. It's a race against time, and even with multiple debridements and perfect care, mortality remains extremely high.
Let's pivot to Section 2, bleeding and ischemia. We're going to look at gross hematuria and priapism.
First up, let's tackle gross hematuria with clot retention. Following your ABCs, the mechanical fix is key here. You want to insert a 3-way Foley catheter. This lets you perform a manual bladder washout and get that continuous bladder irrigation, or CBI, set up. And always correct any underlying coagulopathy. On the investigation side, pull a basic CBC, urinalysis, coagulation profile, and an ultrasound KUB. If the patient is stable, a CT urography is indicated, followed by a cystoscopy after they're stabilized to actually find the source of the bleeding. Definitively, you treat the underlying cause. If your irrigation is failing, you've got to move to an endoscopic clot evacuation, and if you happen to identify a bladder tumor, a TURBT is indicated. Now make sure you lock in these exam pearls. If you see painless, gross hematuria in a clinical stem, boom, immediately think bladder cancer. The strongest risk factor for that? Smoking. Just remember that 3-way catheter is essential for irrigation, and persistent clot retention strictly requires endoscopic evacuation. Next up is priapism, which brilliantly illustrates a major clinical crossroad. Right after your ABCs and providing adequate analgesia, you face an absolute necessity. You must immediately determine if it's the ischemic or non-ischemic type. Your investigations are going to directly support this, so order a cavernosal blood gas and a Doppler ultrasound to check out the blood flow.
Once you've identified an ischemic priapism, you follow a really strict, rapid escalation of care. Step 1, immediate aspiration of corporal blood. Step 2, if aspiration isn't doing the trick, you inject intracavernosal phenylephrine. Step 3, if the whole thing is still refractory, you escalate immediately to a surgical shunt.
And the strict indication for that surgical shunt is specifically the failure of both aspiration and phenylephrine. Let's punch in these high-yield facts. Ischemic priapism isn't just uncomfortable, you guys, it's a true urological emergency. An erection lasting more than 4 hours requires urgent treatment to prevent permanent erectile dysfunction. And for those clinical vignettes, keep in mind that sickle cell disease is a highly common underlying cause. Keep that front and center in your mind.
Okay, moving right along to Section 3, penile trauma and swelling. We're tackling paraphimosis and penile fracture.
Starting with paraphimosis, your immediate goal is physical decompression. Provide adequate analgesia, reduce the edema using compression or ice, and then attempt manual reduction. Notice our diagnostic approach here. We aren't wasting time on complex imaging. This is almost exclusively a clinical diagnosis. You see it, you treat it.
Now, if manual reduction fails, you move to definitive surgical management, which is a dorsal slit. Then, after the acute inflammation finally settles down, a circumcision is performed to prevent recurrence. So, your definitive indications for surgery are failed manual reduction or recurrent paraphimosis. Note this carefully. This is an absolute emergency, because any delay whatsoever can cause severe glands ischemia and necrosis.
Our second trauma emergency is a penile fracture. Initial management is pretty much exactly what you'd expect for acute blunt trauma: ABCs, analgesia, ice packs, and an immediate urology referral. For investigations, again, it's usually a clinical diagnosis, but there's a major caveat here. You must order a retrograde urethrogram if you even suspect an associated urethral injury.
Definitive management here is immediate surgical exploration and repair. The pearls here are classic board material, guys. If a patient reports a loud snap sound, followed by sudden pain and rapid detumescence, that's a penile fracture until proven otherwise. Remember that associated urethral injury risk we just talked about. And let's be totally clear about the outcome. Early surgery definitively gives the best results. Attempting conservative treatment just leads to significantly higher complication rates.
All right, home stretch. Section 4, scrotal and renal infections. We're looking at epididymo-orchiditis and emphysematous pyelonephritis.
Taking a look at acute epididymo-orchiditis, initial ER management is largely supportive. We're talking analgesia, NSAIDs, scrotal elevation, empirical antibiotics, and hydration. But the diagnostic phase holds a real danger zone. Yes, you need a urinalysis, urine culture, and STI testing, but most critically,
You absolutely must order a Doppler ultrasound if testicular torsion cannot be 100% excluded.
Definitively, you'll use culture-directed antibiotics, treat any STIs, and drain an abscess if one manages to form. Now pay super close attention to this clinical warning. Epididymo-orchitis usually presents with a gradual onset of pain, fever, and a preserved cremasteric reflex. The pain also often improves with scrotal elevation, which is known as the Prenz sign. But hear this loud and clear. Never, ever rely on the Prenz sign to exclude torsion. You must definitively exclude torsion before you even think about just treating for epididymo-orchitis.
Our final condition today is emphysematous pyelonephritis. Initial management here has a massive metabolic focus. Along with your ABCs, aggressive IV fluids, and broad-spectrum antibiotics, you need tight glycemic control and an urgent urology consult. Why the metabolic focus? Well, we'll see in a second. First, check out the investigations. You need your CBC, renal panels, and cultures, but the absolute, unquestionable gold standard for diagnosis is right there, a CT scan showing gas within the renal parenchyma or the collecting system.
Definitively, this means percutaneous drainage plus antibiotics or an outright nephrectomy for really extensive disease. The exam pearls tie the whole clinical picture together. This condition commonly occurs in diabetic patients, hence the absolute need for that glycemic control. Gas-forming organisms are responsible for the disease pathology here. As we mentioned, CT is the best imaging modality. And critically, any delay in treatment significantly increases mortality.
Starting right at the kidneys with Section 1, urolithiasis. This is a 5-star importance topic. So, in the ER, we follow a pretty strict flowchart. Step 1, always your ABCs, airway, breathing, circulation, and checking hemodynamic stability. For step 2, pain control is absolutely paramount. NSAIDs are going to be your first-line choice here, alongside IV fluids and antiemetics if they need them. Step 3 is highly practical. Strain the urine to catch that stone for analysis. But I want you to pay very close attention to step 4. I want to put heavy emphasis on this. If your patient has a fever, combined with an obstruction, that is an absolute surgical emergency. You have to decompress immediately. Okay, once the patient is stabilized, we move methodically through our workup. You need a urinalysis to check for red blood cells, infection, and pH, along with a CBC and renal function tests. For your recurrent stone formers, make sure you check serum calcium and uric acid. But the absolute gold standard, the investigation of choice, is the non-contrast CT KUB. Just remember to pivot to an ultrasound KUB if your patient is a child or pregnant. And, keep the X-ray KUB in your back pocket for following up on radiopaque stones. Remember, no detail here can be skipped on exam day. And this brilliantly illustrates how stone size literally dictates our definitive surgical or medical management path. If it's less than 5 millimeters, we stay conservative, hydration and analgesia. Between 5 and 10 millimeters, we're kind of in a gray area, choosing between medical expulsive therapy or an intervention, and that really just depends on the patient's symptoms. But once that stone hits 10 millimeters or more, you're almost certainly looking at an intervention like ESW, URS, RARS, or PCNL. Now, beyond just the size of the stone, when do we actually definitively intervene? Think of me as your senior attending demanding rapid recall on rounds right now. You step in for these 7 reasons: persistent pain, obstruction, infection, renal impairment, if the patient only has a solitary kidney, if there's a failure of spontaneous passage, or if there's just a massive stone burden. Memorize these triggers for sure. All right, consider this our first high-yield neon sign box of the explainer. If you take away anything, insist on remembering the drain first, stone later rule for infected, obstructed kidneys. It is absolutely vital. Also, you've got to lock in these stone compositions. Calcium oxalate, that's the most common. Uric acid stones are sneaky because they're radiolucent. Struvite stones go hand in hand with urease-producing bugs, often forming those massive staghorn shapes that fill the whole renal pelvis. And cystine stones equals cystinuria. Let's transition smoothly down the urinary tract to our second critical condition, ureteric colic, also extremely important. Notice the algorithmic rhythm of the ER protocol here. It's highly similar to our previous steps. ABCs first, right? NSAIDs and antiemetics second. Hydrate them if they need it. And always assess for fever and sepsis at step 4. Now, what's really interesting about this slide is how we pivot straight from investigation directly to conservative versus invasive action based entirely on infection status. Your labs and imaging are exactly the same as for renal stones, relying heavily on that non-contrast CT. But infection status is the ultimate fork in the road. No infection? great. You can manage conservatively or schedule a ureteroscopy or ESWL. But if there is an obstruction with infection, you're placing a double J stent or a percutaneous nephrostomy immediately. No waiting. Listen up. Here are your clinical pearls for colic, and I'm delivering these with urgency. The pain classically radiates from the loin down to the groin. Don't be fooled if there's no blood in the urine, though. Hematuria is common, but it can absolutely be absent. Fever with colic, that is your siren for an infected obstruction. And whatever you do, never ever rely solely on an X-ray KUB for your diagnosis. It will miss things. All right, let's head down to the base of the urinary tract for a major source of lower tract emergencies. Section 3, benign prostatic hyperplasia. Think of this as your immediate triaging process when a patient presents with a sudden inability to void. Step 1 is assessing the severity of their LUTS. That's lower urinary tract symptoms. If they are in acute urinary retention, meaning they literally cannot pee, Step 2 is immediate catheterization. Only after that do you consider Step 3, starting an alpha blocker to help open things up. So the absolute crucial point here is timing that PSA draw. We naturally get a urinalysis, renal function tests, and an ultrasound to check the post-void residual volume. But with the PSA, never draw it during acute retention or right after a digital rectal exam. Both of those events artificially spike the PSA levels and totally ruin your diagnostic baseline. This table right here is going to guide you through the escalating tiers of therapy. Mild symptoms, we do watchful waiting. Moderate, medical therapy. But if symptoms are severe, we're looking at surgery like a TURP. Let me explicitly lay out the absolute triggers for surgical intervention. If your patient has recurrent retention, recurrent UTIs, recurrent hematuria, bladder stones, renal impairment, or if their meds just aren't cutting it anymore, it is time to operate. Okay, pay attention to this stark anatomical difference because it's a classic high-yield board exam trap. BPH arises from the transition zone right around the urethra, which is exactly why it causes obstruction so early on. Prostate cancer, on the other hand, typically arises from the peripheral zone. Keep them straight. Let's hammer home these final BPH rules. Transurethral resection of the prostate, or TURP, remains the gold standard surgery for appropriately sized prostates. Always anticipate acute urinary retention as a common complication. And please remember the diagnostic limit. An elevated PSA is a helpful clue, but it is not definitively diagnostic of prostate cancer on its own. Moving right along to Section 4, hydronephrosis. Notice that subtitle? It's a sign, not a diagnosis. Super important distinction there. Keeping the pace fast and focused, here are your stabilization steps and imaging modalities grouped together. You must assess renal function, relieve the obstruction, and treat any infection immediately. To figure out what's actually causing the backup, you start with an ultrasound KUB. If you suspect a stone, the investigation of choice is the non-contrast CT KUB. And sometimes a CT urography is indicated just to map out the anatomy. Let's move to definitive management and see how this builds into a really critical understanding. You manage it by treating the underlying cause, often placing a double J stent or a percutaneous nephrostomy to buy some time. But remember that final pearl. Bilateral hydronephrosis will cause AKI. And if you have infection plus hydronephrosis, that kidney is a ticking time bomb. It is an absolute, unquestionable emergency. And that brings us to our final, overarching systemic consequence of all the mechanical issues we've just covered. Section 5, obstructive uropathy. I want you to walk through this timeline exactly as if you're running a trauma bay. Stabilize first, decompress second, cure third. In the immediate phase, you manage ABCs, fix the fluids and electrolytes, and hit the sepsis hard. In the urgent phase, you get in there and relieve that obstruction. In the definitive phase, you tailor your hardware, a Foley catheter for lower tract tissues, or a double J stent or PCN for upper tract tissues, followed by treating the actual root cause. I really want to emphasize the physiological cascade happening here. You're drawing your CBC, renal panels, and electrolytes. Why? Because mechanical plumbing issues cause life-threatening systemic problems. Bilateral obstruction causes AKI, which leads to hyperkalemia, which can literally stop a heart. Relief of the obstruction is your only priority. And once you do relieve it, you have to monitor their fluid output, because post-obstructive diuresis can severely dehydrate the patient. Let's start our journey right at the top of the urinary tract with Section 1, the kidneys. And we've got two absolutely crucial, highly tested conditions to cover here: staghorn calculus and PUJ obstruction. First up is staghorn calculus. Now guys, this is a massive, 4-star, highly tested topic. I really want you to lock in this one-line recall. Staghorn calculus is the struvite stone that threatens the kidney. Seriously, if you remember absolutely nothing else today, start with that. Okay, so how do we handle a staghorn? Your immediate initial move is always assessing for sepsis and obstruction. Start those IV antibiotics if they're infected, and for sure relieve the obstruction if indicated. When it comes to investigations, grab your baseline labs, your CBC, renal function tests, and a urine culture. But listen closely, the absolute gold standard here, that's the non-contrast CT-KUB. You're also going to want a DTPA or MAG3 scan to check out their split renal function. And then definitively, PCNL, percutaneous nephrolithotomy, is your go-to treatment choice. If you're dealing with a massive stone burden, you do a staged PCNL. And if the kidney is completely non-functioning, well, unfortunately, that requires a nephrectomy. So why do we operate in the first place? Well, you intervene if the stone is symptomatic, if it's causing recurrent infections, if you see declining renal function, or if there's persistent obstruction. And here is a huge exam pearl for you. These are usually struvite stones. Those are infection stones that are super heavily associated with Proteus infections. Remember, your surgical goal has to be complete clearance, because leaving even tiny fragments behind will literally inevitably destroy that kidney. Moving on, our next topic is PUJ, or pelviuretic junction obstruction. Again, this is another critical 4-star topic. Your one-line recall right here is PUJ obstruction is the pediatric hydronephrosis heavyweight. For a PUJ obstruction, your initial management is going to focus on relieving that obstruction, especially if it's infected or renal function is rapidly tanking, along with treating any active infection. As for investigations, an ultrasound, KUB, and CT urography are great starting points. But the absolute gold standard you need to click on that exam, that's the DTPA or MAG3 renogram. That tells you exactly what you need to know about drainage and split renal function. Definitively speaking, the gold standard surgery is a pyeloplasty, though an endopilotomy does have a role for highly selected patients. Now, what's really interesting about this slide is understanding the pearls you absolutely must know. PUJ obstruction is the most common cause of hydronephrosis in kids. Anatomically, a crossing lower pole vessel is usually the culprit. You really want to lock in the name of that gold standard surgery, the Anderson-Hines pyeloplasty. You'll go in surgically for symptoms, progressive hydronephrosis, impaired function, recurrent infections, or stones. All right, moving anatomically down the urinary tract, we arrive at section 2, the bladder. Here we're going to tackle 2 solid 3-star rated conditions, the sicko-ureteric reflux and neurogenic bladder. Starting with VUR, your one-line recall is, vesico-ureteric reflux is the pediatric recurrent UTI culprit. Your initial goal is super simple, treat the UTI and actively prevent recurrences. To investigate, you start with an ultrasound KUB, but the absolute gold standard, that's the MCUG, the micturating cystourethrogram. You're also going to use a DMSA scan specifically to hunt for any renal scarring. Depending on how severe it is, your definitive management can range anywhere from simple observation for low-grade reflux to daily antibiotic prophylaxis, all the way up to a ureteric reimplantation for those persistent high-grade cases. Guys, pay really close attention to these clinical tropes. VUR is an incredibly common cause of recurrent UTIs in kids, and if you leave it unchecked, it leads straight to reflux nephropathy. You need to know that the MCUG is your absolute investigation of choice. Seriously, know it cold. You're basically committing to surgery if you see high-grade reflux, breakthrough UTIs even when they're on antibiotics, or progressive renal scarring. Next up is neurogenic bladder, which is another solid 3-star topic. For neurogenic bladder, initial management basically means providing immediate drainage if the patient is in retention, treating any UTIs, and above all else, protecting their overall renal function. Your gold standard investigation here isn't just basic imaging, actually. It's urodynamic studies to completely understand the pressures inside that bladder. Definitively, you're going to rely heavily on clean intermittent self-catheterization, or CISC, and anticholinergic meds to calm down an overactive bladder, basically reserving surgery only for the really severe cases. So the crucial point here is understanding the underlying causes. Diabetes and spinal cord injuries are your classic culprits, but your ultimate treatment goal, it's actually renal preservation. It's all about protecting the kidneys above the bladder. And that is exactly why clean intermittent self-catheterization, CISC, is vastly preferred over just leaving a chronic Foley catheter sitting in place. Let's transition into section 3, ureteric strictures and diuresis. We're going to focus on ureteric complications and the pretty severe physiological fallout that happens when we finally relieve a chronic urinary obstruction. First is the ureteric stricture, a 3-star topic. Your one-line recall here is simple. Ureteric stricture is the blocked pipe. For a ureteric stricture, your initial move is just to relieve the obstruction with a DJ stent, or a PCN if necessary. Next, you gotta map out the anatomy thoroughly with CT urography and retrograde pylography. A renal scan is gonna help if the kidney's baseline function is a bit uncertain. Definitively, while you absolutely can attempt endoscopic dilation, long or stubborn strictures usually demand a formal ureteric reimplantation or reconstruction. You really need to memorize this triad of causes for strictures: prior surgery, stones, and radiation. Think of this as a high-yield memory box. If you ignore a stricture, the whole system backs up, causing hydronephrosis and eventually permanent renal impairment. Now, when you finally relieve a severe obstruction, you trigger post-obstructive diuresis. This is another 3-star topic. The recall for this one? It's the flood after the dam breaks. Your initial management requires intense vigilance. We're talking strict hourly urine output monitoring and fluid replacement that matches those losses. You've got to keep a super close eye on electrolytes and take daily weights, because your definitive management is entirely about supportive care and diligently correcting dangerous imbalances. Please never underestimate this physiological danger. Right after the relief of a chronic obstruction, a patient can easily dump several liters of urine in just a few hours. This massive polyuria causes rapid, life-threatening dehydration and hypokalemia. That drop in potassium, it is incredibly dangerous. Therefore, careful, measured fluid replacement is completely non-negotiable. Let's move on and see how this builds into our final and honestly, perhaps most critical section, essential urinary diversion. This right here is where clinical pattern recognition is everything. Urinary diversion is a huge, 4-star, heavily tested exam favorite. This topic requires absolute, total mastery because you're going to be tested on exactly which tube goes where and precisely when to use it in really complex clinical scenarios. Let's contrast the methods and their indications in this table. You're going to use a Foley catheter for acute urinary retention and output monitoring. Reach for a suprapubic catheter, or SPC, if there's a urethral injury or a failed Foley attempt. Moving higher up the tract, a double J, or DJ stent, is for ureteric obstruction, post-ureteroscopy management, or ureteric injury. Finally, the PCN, the percutaneous nephrostomy, that's your absolute go-to for an obstructed, infected kidney when retrograde access just isn't possible. To simplify your clinical decision-making, just remember this basic geographic rule. Lower tract obstruction, you're reaching for a Foley or an SPC. Upper tract obstruction, you're looking at a DJ stent or a PCN. Recognizing whether the problem is above or below the bladder dictates your entire diversion strategy. And this brilliantly illustrates the absolute hard rules for PCNs and SPCs. If a DJ stent fails, or in cases of severe sepsis, you escalate immediately to a PCN. Conversely, you must never place an SPC if there is suspected bladder cancer right at the puncture site, or if you don't have a safely distended bladder to puncture into. That is absolutely critical.
Neurogenic bladder, the malfunctioning reservoir.
So when we're managing a neurogenic bladder, we're basically moving from immediate relief to definitive care. Step 1, the initial phase. You absolutely must assess for urinary retention. If it's acute, place a Foley catheter right away. Treat any UTI and keep a really close eye on that renal function. Okay, step 2, investigate. Once they're stabilized, you're going to want a urinalysis, a culture, and an ultrasound KUB to check the post-void residual. But, and definitely star this in your notes, a urodynamic study is your absolute gold standard here. You'll also want an MRI of the spine or brain if you suspect a central neurological cause. And finally, step 3, definitive management. Clean intermittent self-catheterization, or CISC, is highly preferred. Medically, we can use anticholinergics, beta-3 agonists, or even intradetrusor Botox. And for the really refractory cases, augmentation cystoplasty is definitely on the table.
Now, surgery obviously isn't step 1. We really only escalate to the operating room for 3 main reasons. First, failure of conservative treatment. Second, poor bladder compliance that is actively threatening renal function. Or third, recurrent severe infections. Basically, we only reserve the knife for when the conservative path has completely failed us.
To really lock this into your memory for the boards, let's contrast the primary etiologies. The most common medical cause of a neurogenic bladder, that's diabetes. Compare that to the most common traumatic cause, which is a spinal cord injury. You've got to keep these 2 distinct pathways in mind whenever you evaluate a patient with a malfunctioning bladder.
All right, let's lock in these absolute must-know surgery exam pearls. First, the main aim of all this management is the preservation of renal function, period. Second, a urodynamic study is your gold standard investigation. And third, for definitive care, clean intermittent self-catheterization is always preferred over leaving a long-term fully in place.
Section 2. Vesico-ureteric reflux, or VUR, the dangerous backflow.
Moving on to VUR, our initial step here is immediate. Treat the UTI and aggressively try to prevent recurrent infections. From there, we move to step 2, investigation. You'll order a urinalysis, a urine culture, and an ultrasound KUB. But the gold standard to actually visualize that reflux, that's your MCUG or VCUG. And to check for permanent damage, you're going to order a DMSA scan to detect any renal scarring. Finally, step 3, definitive management. This actually ranges pretty widely based on severity. We might just do simple observation for low-grade reflux, maybe throwing in some antibiotic prophylaxis. Moving up the ladder, we can use an endoscopic deflux injection. And for high-grade reflux, that means formal ureteric reimplantation.
So when do we actually operate for VUR? Well, the indications are pretty clear-cut. High-grade reflux, recurrent febrile UTIs, progressive renal scarring, or failed conservative management. Notice the theme there. Progressive renal scarring and those recurrent febrile episodes literally dictate that we must physically reconstruct the anatomy to save the kidney.
Here's a massive surgery exam pearl for VUR. It is a super common cause of recurrent febrile UTI in children, which can unfortunately lead to reflux nephropathy. Make absolutely certain you connect the specific imaging modality to its specific purpose for the exam. Remember, the MCUG confirms the diagnosis of reflux, while the DMSA scan detects the resulting renal scarring. Don't mix those up.
Section 3. Ureteric stricture, the physical blockage.
Okay, our approach here in step 1 starts with an absolute emergency mindset. You have to relieve the obstruction immediately with a DJ stent, or a percutaneous nephrostomy if required, and of course, treat any infection. Step 2, once they're decompressed, you investigate. Check their renal function tests, perform CT urography to map out the anatomy, or use retrograde pyelography. If the actual function of the kidney is uncertain, a nuclear renal scan is going to be necessary. Ultimately, step 3, definitive management, is reconstructive. This could mean balloon dilation, endoureterotomy, a ureterostomy to connect healthy segments, or ureteric reimplantation for strictly distal strictures.
So the crucial point here is knowing exactly when to jump to those definitive surgeries. The indications are symptomatic obstruction, progressive hydronephrosis, declining renal function, and recurrent infections. Once again, declining function and progressive dilation basically force the surgeon's hand. We simply cannot let the kidneys slowly drown.
Let's hit the high-yield surgery exam pearls for strictures. The most common pauses are previous surgery, impacted stones, and radiation. Left untreated, these strictures will inevitably lead to hydronephrosis. And remember this one. Placing a DJ stent only provides temporary relief. It's a bridge to definitive treatment, not a permanent cure.
Section 4. Hydroureter, the consequence.
Never ever forget this crucial point. Hydroureter is a dilatation of the ureter. It is not a diagnosis. I say this with a lot of energy because so many learners get trapped right here. Seeing a dilated ureter is literally just the beginning of your job. You must always hunt down the underlying cause.
Step 1 for management here is to identify and relieve the cause of obstruction and treat any associated infection. To find that cause, step 2 is investigation. You use ultrasound KUB and NCCT KUB if you suspect a stone, CT urography, and check those renal function tests. Once identified, step 3, definitive management, operates kind of like a matching game, where your treatment strictly depends on the pathology you uncovered. If it's a stone, you remove it. If it's a stricture, reconstruct it. If it's VUR, use the appropriate management we talked about. And if it's a tumor, you proceed to oncological treatment.
Your surgery exam pearl here ties it all together beautifully. Hydroureter usually occurs secondary to a distal obstruction. And importantly, long-standing cases of this fluid backing up may eventually progress to hydronephrosis, which directly compromises the kidney itself.
Section 5. Post-obstructive diuresis, the systemic floodgate. Because the fluid shift here can be absolutely staggering, management requires a serious intensive care mindset. In step 1, initially, you must monitor urine output hourly and replace about 50 to 75% of those urine losses with IV fluids. Closely monitor blood pressure and hydration, and check those electrolytes regularly. Throughout this, step 2 requires frequent serum electrolyte checks, renal function tests,
a really meticulous fluid balance chart, and even daily weights if this is prolonged. Finally, step 3, definitive management, is essentially highly vigilant supportive care. You're correcting electrolyte abnormalities on the fly and gradually reducing IV fluids as that massive diuresis resolves.
Now, what's really interesting here is the sheer massive volume we are talking about. Post-obstructive diuresis isn't just, a slightly full catheter bag. It is strictly defined as a polyuria exceeding 3 liters per day or output greater than 200 milliliters per hour for 2 consecutive hours. That is a ton of fluid. Let's look at the surgery exam pearls for this dangerous phase. This phenomenon classically occurs after you relieve a bilateral or chronic urinary obstruction. And because of that massive fluid shift, it can cause severe dehydration, hypovolemia, hypokalemia, and dangerous hypotension. Careful hourly monitoring is absolutely paramount to prevent these potentially fatal complications. Thankfully, it usually resolves within 24 to 48 hours, though it can definitely persist in severe cases.
All right, section 1. Let's start up at the kidneys with renal cell carcinoma, or RCC. This is a 5-star, extremely important clinical topic.
Now, the core algorithm for handling suspected RCC always kicks off with patient safety. Assessing hemodynamic stability, controlling pain or hematuria, and getting that multidisciplinary team discussion going. From there, your definitive management is totally dictated by tumor size and spread. So if you've got a T1 tumor, meaning it's under 7 centimeters, a partial nephrectomy is what you're aiming for if feasible. But for large, localized tumors, you're looking at a radical nephrectomy. And if it's metastatic, well, the whole paradigm shifts toward immunotherapy or targeted therapies, sometimes with a cytoreductive nephrectomy depending on the patient.
When it comes to imaging, I really want you to burn this into your memory. The absolute gold standard, the investigation of choice, is a contrast-enhanced CT of the abdomen and pelvis. It's your definitive first step anytime you suspect RCC.
Okay, beyond that gold standard CT, a proper diagnostic workup includes your baseline labs, think CBC, renal function tests, urinalysis, plus a chest CT to check for metastases. Oh, and if you suspect an inferior vena cava thrombus, getting an MRI is absolutely crucial. Now notice that a renal biopsy isn't routinely indicated before surgery. Usually, the imaging is suspicious enough that you just proceed right to the surgical intervention. Now, the rules for kidney-sparing surgery are actually incredibly specific. A partial nephrectomy isn't just for tumors 7 centimeters or smaller. It is absolutely vital if the patient has a solitary kidney, bilateral tumors, or pre-existing chronic kidney disease. Basically, anytime you desperately need to preserve nephron mass. As for some high-yield pearls, clear cell is by far the most common subtype, and smoking, that's the strongest modifiable risk factor. You've also probably heard of the classic diagnostic triad, hematuria, flank pain, and a palpable mass, but honestly, seeing all 3 of those together is actually pretty rare nowadays. RCC is also notorious for aggressively invading the renal vein and the IVC. Clinically, if you have a male patient presenting with a new-onset left-sided varicocele, alarm bells should be ringing. Why? Because a left renal vein tumor thrombus can literally block the left gonadal vein drainage. If the cancer does spread, the lungs are the most common site for distant metastases. RCC is also famous for paraneoplastic syndromes. Ectopic hormone production can lead to polycythemia, hypercalcemia, hypertension, and even a non-metastatic hepatic dysfunction known as Stauffer syndrome. All right, moving down the urinary tract, we hit section 2, bladder cancer. This is another 5-star, extremely important pathology you simply cannot ignore. If you take away literally nothing else from this section, let it be this one universal clinical truth. Painless hematuria is bladder cancer until proven otherwise. Seriously, do not ignore it or pass it off as just a UTI in an older patient without doing a thorough workup first.
When it comes to management, the pathway here hinges almost entirely on one thing. Has the tumor invaded the detrusor muscle? Initially, your goal is to stabilize the gross hematuria, maybe using a 3-way Foley with continuous bladder irrigation for clot retention, and obviously referring them to urology. But for definitive care, non-muscle invasive disease is usually managed with a TURBT, that's a transurethral resection of bladder tumor, sometimes alongside intravesical therapies like BCG or mitomycin. But the moment it becomes muscle invasive, that's a huge threshold. You're looking at a radical cystectomy with urinary diversion, often paired with neoadjuvant chemo. And of course, metastatic disease means moving to systemic therapy.
Let's step through the diagnostic pathway chronologically. Step 1 is always a urinalysis and urine cytology to check for malignant cells. Step 2 is your gold standard, the investigation of choice, a cystoscopy with biopsy or a TURBT.
What's really unique about TURBT is that it's acting as both your diagnostic tool and your initial therapeutic tool at the exact same time. Finally, if you suspect muscle invasion during that scope, you'll need a CT urogram and pelvic imaging, like a CT or MRI, to get accurate staging.
Keep in mind, a radical cystectomy isn't strictly reserved just for muscle-invasive disease. It's actually also indicated for high-risk recurrent non-muscle invasive cancer, or if initial therapies like BCG just fail. Here are some other fascinating pearls for you. Urothelial, which we used to call transitional cell carcinoma, is the most common type, with smoking being the absolute strongest risk factor. But here's a highly tested geographic association. A history of a schistosomized infection is strongly linked to squamous cell carcinoma of the bladder. Ultimately, remember that the depth of muscle invasion is the main thing that determines the patient's prognosis.
Okay, moving right along, let's dive into prostate cancer, Section 3. And yep, it's another 5-star, extremely important topic.
The management of prostate cancer maps out a pretty wide spectrum. Initially, you're assessing for lower urinary tract symptoms, bone pain, weight loss, or hematuria. You're doing a digital rectal exam, or DRE, and getting that urology referral. But definitive care is really tailored to the risk. Active surveillance is often the best move for low-risk disease. As severity bumps up, your options expand to a radical prostatectomy, external beam radiotherapy, and androgen deprivation therapy, all the way up to chemotherapy for metastatic castration-resistant cases.
For the diagnostic workup, you're obviously looking at PSA levels and a DRE, where a hard, irregular nodule is a massive red flag. A multiparametric MRI is often used nowadays to identify specific targets, though the true gold standard is still a TRUS-guided or MRI-targeted biopsy. If you suspect the cancer has spread, you'd order a bone scan or a highly sensitive PSMA PET-CT. It's also worth noting that a radical prostatectomy is a major surgery, so it's generally only indicated if the disease is completely localized and the patient is fit, with a life expectancy of more than 10 years.
Some key pearls here. Prostate cancer arises predominantly from the peripheral zone of the gland. Also remember that PSA is a screening and monitoring tool. It's not inherently diagnostic on its own. Now, if the cancer spreads to the bone, the metastases are uniquely osteoblastic, meaning they actually build abnormal hardened bone, and they heavily favor the vertebral column. And finally, it's the tissue architecture, which we grade with the Gleason score, that ultimately predicts how aggressive the tumor is going to be.
All right, let's move down to our final anatomical stop, testicular tumors. This is a 4-star, very important topic, and it comes with some incredibly strict clinical rules you've got to follow. So, following an urgent urology referral, there is a massive clinical rule I want you to remember. Never, ever perform a transscrotal biopsy. Violating the scrotum like that can actually alter the lymphatic drainage and push the cancer into the inguinal lymph nodes instead of its natural retroperitoneal pathway. Because of this, after you counsel young men about sperm banking, the definitive standard of care for any suspected malignancy is a radical inguinal orchidectomy. You remove the testicle through an incision in the groin, never the scrotum. That's usually followed by surveillance, chemo, or radiation. Because we can't just go in and biopsy directly, your primary non-invasive workup leans heavily on the scrotal ultrasound. It's fantastic at distinguishing a solid mass from a cystic one. You combine that imaging with a very specific trio of serum tumor markers, AFP, beta-HCG, and LDH. For staging, you're going to need a full CT of the chest, abdomen, and pelvis to check for any lymph node involvement or distant spread.
Let's look at some key pearls. Germ cell tumors are by far the most common category here, with the seminoma being the most common single subtype. But here is an absolute rule you have to know. A pure seminoma will never, ever show an elevated AFP. If that AFP level is high, you are dealing with a non-seminomatous germ cell tumor, period. As for lymphatic spread, testicular cancer follows its blood supply right up to the para-aortic lymph nodes first. Oh, and just like painless hematuria with the bladder, any painless testicular swelling should be considered malignant until proven otherwise.
Okay, time for the main event, Section 5. This is our high-yield, lightning round of last-minute exam recalls to really lock all of this into your short-term memory.
First up, let's quickly contrast these two incredibly high-yield anatomical zones that examiners absolutely love to test. Prostate cancer arises in the peripheral zone, which is exactly why you can feel it during a digital rectal exam. Conversely, benign prostatic hyperplasia, or BPH, arises in the transition zone right around the urethra, which is why it causes those early urinary symptoms.
Now let's run through some rapid-fire clinical associations to instantly connect the clinical clue to the right answer. Most common RCC subtype? Clear cell. A key characteristic of RCC, it loves to invade the renal vein and IVC. An older male presents with a new left-sided varicocele? Suspect RCC. The classic presentation of bladder cancer? Painless hematuria. The major shared risk factor for both RCC and bladder cancer? Smoking. A patient has a history of schistosomiasis? You should be thinking squamous cell carcinoma of the bladder. And the gold standard diagnosis for bladder cancer? Cystoscopy plus 2-BRT.
And we'll wrap up these recalls with 5 absolute truths for prostate and testicular pathologies. Bone mets in prostate cancer? Always think osteoblastic. The role of PSA? It's strictly for screening and monitoring, not diagnostic. The surgical gold standard for a testicular tumor? Radical inguinal orchidectomy. Again, never a scrotal approach. What happens to AFP in a pure seminoma? It is never elevated. And finally, the first site of spread for testicular cancer? The para-aortic lymph nodes.
Retroperitoneum. All right, think like a surgeon here. When you're evaluating an adrenal tumor, your absolute first priority is assessing its function. If you even suspect a pheochromocytoma, you must get that blood pressure under control before you do anything else. Next step, you investigate with a full hormonal profile and your imaging of choice, which is going to be a contrast-enhanced CT or an MRI of the abdomen, along with functional imaging if indicated. And finally, for management, you're looking at a laparoscopic removal for the benign functioning tumors or an open adrenalectomy if the mass is large or suspected to be malignant. So when do we actually operate? The surgical indications are pretty clear-cut: functioning tumors, suspicious or rapidly enlarging masses, and tumors strictly greater than 4 to 6 centimeters, depending on the specific imaging features. Now here is a massive, and honestly kind of surprising, clinical pearl. Most of those adrenal incidentomas you just stumble across while scanning a patient for something entirely different. They're actually just non-functioning adenomas. So the crucial point is this: alpha blockade before beta blockade. I literally cannot emphasize this enough. If you are dealing with a pheochromocytoma, never, ever start a beta blocker first. Doing that without a prior alpha blockade is an absolute contraindication. It can actually precipitate a life-threatening hypertensive crisis. It's one of those mistakes you really only make once. Shifting gears over to pediatric oncology and the Wilms tumor or nephroblastoma. First step, immediately refer to pediatric surgery or urology and control their hypertension. And critically, pay attention to this one. Do not perform unnecessary palpation of that abdominal mass. Just don't do it. For the workup, you'll grab a CBC and renal test and start with a basic abdominal ultrasound. But keep in mind that a contrast-enhanced CT of the abdomen and chest is your absolute gold standard for staging. Histopathology confirms your diagnosis, and definitive management usually involves a radical nephrectomy, stage-based chemotherapy, and occasionally selected radiotherapy. So, surgery is indicated if the Wilms tumor is resectable. If you've got bilateral disease on your hands, nephron-sparing surgery post-chemo is required. Now for the exam pearls, and these are pure gold. Wilms is the commonest renal malignancy in children, and it classically presents as a painless mass. And where does this thing most commonly spread? Actually, the lungs. It's also heavily associated with some key syndromes you need to recognize: WAGR, Dennis-Drosh, and Beckwith-Wiedemann syndromes. 2 to 5. That is the peak age range in years for a Wilms tumor presentation. Whenever you see a pediatric patient right in this specific 2 to 5 year window presenting with a painless abdominal mass, Wilms tumor should immediately jump to the absolute front of your mind. Okay, jumping back to adults and small renal masses. Step 1. Assess comorbidities and baseline renal function right out of the gate. Your go-to imaging here is a contrast-enhanced CT or MRI, and you'll apply the Bosniak classification for cysts to guide what you do next. Management-wise, that can range anywhere from just active surveillance for carefully selected small masses to a partial nephrectomy or even a full radical nephrectomy if the mass isn't suitable for a nephron-sparing approach. And this brilliantly illustrates how the Bosniak classification system takes all the guesswork out of cystic lesions. Classes I and I, those are benign cysts, you can breathe easy. Class 2F simply requires imaging follow-up. But once you hit Class 3, we're in indeterminate territory, and that usually means a surgical evaluation is needed. Class 4, you have to treat that as malignant until proven otherwise, and it requires definitive intervention. Section 2, the upper tract. We are moving our way structurally down into the ureters. For upper tract urothelial carcinoma, or UTUC, the timeline typically starts with a patient noticing painless hematuria. This kicks off a diagnostic workup heavily reliant on urine cytology, ureteroscopy with biopsy, and CT urography, which is our investigation of choice here. When you get to definitive management, the gold standard procedure is a radical nephroureterectomy, and crucially, you absolutely have to include a bladder cuff excision. Kidney-sparing surgery is really only reserved for very selected low-risk cases. So why do we operate on U to UC? Usually for high-grade tumors, large tumors, or multifocal disease. The histology is typically urothelial. Historically, we called that transitional cell carcinoma. And this is vital. Bladder tumors can occur synchronously, meaning at the exact same time, or they can pop up later down the road. That right there is exactly why that bladder cuff excision we just talked about is so incredibly important. Section 3, the lower tract. We're talking the bladder, urethra, and penis. Let's put two incredibly rare lower tract carcinomas side by side to contrast them. On the one hand, you have urachal carcinoma, which arises from persistent urachal remnants. You refer this out, and investigations will include a CT of the abdomen and pelvis, plus a cystoscopy with biopsy. Management requires a partial cystectomy with en-bloc excision of both the urachus and the umbilicus. Histologically, this is usually an adenocarcinoma, and it often presents with hematuria or even umbilical discharge. Now, conversely, look at primary urethral carcinoma. This presents with urethral bleeding, obstructive symptoms, or a noticeable mass. Your workup here involves urethroscopy with biopsy, a pelvic MRI, and a CT for staging. The management is surgical, with or without chemoradiotherapy, totally depending on the stage. Moving on to penile cancer. First up, assess the lesion and the inguinal lymph nodes immediately, then refer directly to urology. Biopsies are the standard, of course, but image choice really matters here. You want to use an MRI of the penis if you suspect corporal invasion, and rely on a CT scan for checking nodal or metastatic disease. For definitive management, you're looking at a range from organ-preserving surgery for early-stage disease to a partial or total penninectomy for advanced cases, which is often accompanied by an inguinal lymph node dissection when indicated. Surgery is strictly indicated for histologically confirmed invasive penile carcinoma. Now for your exam pearls. Squamous cell carcinoma is by far the most common type. Phimosis and HPV, specifically strains 16 and 18, are major risk factors. But conversely, early circumcision is actually highly protective against it. And anatomically, you've got to remember that the first lymphatic spread goes straight to those inguinal lymph nodes. Section 4, last-minute exam recalls. Let's move to and see how this builds into a rapid-fire review of everything we've just covered. Let's rapidly run through these facts. Wilms tumor versus UTUC. Remember, Wilms is the commonest renal malignancy in children, and the lung is the absolute most common site for metastasis. For UTUC, the definitive treatment is a radical nephroureterectomy, and do not forget to include that bladder cuff excision. Keep that energy up. Next is penile cancer versus pheochromocytoma. Penile cancer is predominantly squamous cell carcinoma. Phimosis and HPV are your major risk factors, and those inguinal lymph nodes are the first site of spread. For pheochromocytoma, come on, say it with me. Alpha blockade before beta blockade, never the other way around. Real quick, recalling the Bosniak classification for cystic lesions. Bosniak 1 and 2, benign cysts. Bosniak 3, indeterminate, which usually means surgical evaluation. And Bosniak 4 carries a very high likelihood of malignancy, so you treat it as malignant until proven otherwise. And finishing up our recalls with the rare carcinomas. Urological carcinoma is usually an adenocarcinoma. Primary urethral carcinoma is exceptionally rare, but you should always suspect it if a patient presents with persistent urethral bleeding or a mass. Urological tumor markers. Imagine you're on rounds and the attending surgeon starts pimping you. You absolutely have to know these cold. So let's run the board. AFP, or alpha-fetoprotein, is raised in yolk sac tumors, embryonal carcinomas, and mixed germ cell tumors. Beta-HCG, that points to choriocarcinoma, mixed germ cell tumors, and some seminomas. Then we have LDH, which is elevated in both seminoma and non-seminomatous tumors. And finally, PSA. It's raised in prostate cancer, sure, but also in BPH and prostatitis. Remember, PSA is absolutely not exclusively diagnostic of prostate cancer. Okay, let's lock in some specific exam pearls here. The standard tumor markers for a testicular tumors are AFP, beta-HCG, and LDH combined. PSA is your go-to for screening, risk assessment, and follow-up. LDH is a great indicator because it reflects the overall tumor burden. But so, the crucial point here, and pay attention because this is a classic trap, AFP should be normal in pure seminoma. Let me just repeat that. AFP is never elevated in pure seminoma. Never. Section 2, common sites of metastasis. Now, bladder cancer doesn't just spread randomly. It actually follows an exact algorithmic stepwise progression. Step 1, it hits the pelvic lymph nodes. Step 2, it moves to the liver. Step 3, it goes to the lung. And finally, Step 4, the bone. Make sure you memorize that sequence. Let's rapidly correlate the rest of the major tumors. Renal cell carcinoma, or RCC. The commonest site of metastasis is the lung. The major exam pearl here? If you see a left-sided varicocele, you must suspect RCC. Prostate cancer goes straight to the bone, classically causing osteoblastic lesions. Testicular tumors, they spread first to the para-aortic lymph nodes. Wilms tumor also heads to the lung. And penile cancer spreads first to the superficial inguinal lymph nodes. Moving on to Section 3, Bosniak cyst classification. All right, let's scale the malignancy risk for renal cysts. We start at Class 1. This is a simple cyst with a thin wall, no septa or enhancement. The malignancy risk is basically 0%, and it requires no treatment. Stepping up to Class 2, you might see a few thin septa, maybe some fine calcification. The risk is still very low, and again, no follow-up needed. Then we hit Class 2F, multiple thin septa or minimal wall thickening. The risk is still low, but management shifts here to follow-up imaging. Class 3 jumps significantly. Now we're looking at a thick or irregular enhancing wall or septa. This carries roughly a 50% malignancy risk, making a partial or radical nephrectomy the management of choice. Finally, Class 4. You'll see an enhancing soft tissue component, like a solid nodule. This is very high risk, greater than 80 to 90%, demanding immediate surgical excision. Now, what's really interesting about this is how easily we can distill it into exam pearls. Bosniak 1 and 2 are benign. Easy. For Class 3F, just remember the F literally stands for follow-up. That's your memory hook right there. Class 3 is technically indeterminate, but it's often malignant. And Class 4, you treat that as RCC until proven otherwise. Oh, and remember, a contrast-enhanced CT is the commonly used imaging modality to classify all of these. Section 4, High-Yield Disease Comparisons. First up, BPH versus prostate cancer. Geographically, BPH happens in the transition zone, while prostate cancer hides out in the peripheral zone. On a physical exam, a benign BPH feels smooth and enlarged. This completely contrasts the hard, irregular feel of a malignant prostate cancer. Symptomatically, BPH presents predominantly with lower urinary tract symptoms or LUTS. Prostate cancer, on the other hand, is often asymptomatic early on or might present with bone metastasis. For BPH, the treatment is typically a TURP, but for localized prostate cancer, the path is a radical prostatectomy or radiotherapy. Next, let's contrast adult and pediatric renal masses. RCC versus Wilms tumor. RCC strikes adults, often with a history of smoking, whereas Wilms tumor appears in children and is linked to congenital syndromes. RCC commonly alerts you with hematuria, but Wilms often presents silently as just a painless abdominal mass. Surgically speaking, RCC requires a radical or partial nephrectomy, but Wilms requires a nephrectomy plus chemotherapy. The big shared traits, remember here, is that both of them ultimately metastasize to the lung. Let's look at testicular tumors, seminoma versus non-seminomatous germ cell tumors. NSGCTs tend to hit earlier, right in the 20 to 30 age range, while seminomas hit about a decade later, in the 30 to 40 range. Re-anchoring those marker rules from earlier, seminomas are radiosensitive with a better prognosis and a strictly normal AFP, whereas NSGCTs are less radiosensitive, much more aggressive, and commonly elevate both AFP and beta-HCG. When it comes to bladder cancer, staging changes absolutely everything. Non-muscle invasive disease, which includes TA, T1, and CIS, is treated with TURBT, with or without BCG, yielding a generally better prognosis. This directly contrasts with muscle-invasive bladder cancer. That's stage T2 and above, and it requires a radical cystectomy with or without neoadjuvant chemotherapy, carrying a much, much higher risk of metastasis. So, when do we actually save the kidney? Well, a partial nephrectomy is for small, localized tumors. It preserves renal function, and honestly, it's preferred whenever it's technically feasible. A radical nephrectomy, however, is reserved for large, localized tumors, involves removing the entire kidney, and is used only when nephron-sparing surgery is completely impossible. Section 5, Essential Staging Pearls. Let's move to testicular tumor staging and see how this builds. It's basically a physical upward progression. Stage 1 is confined to the testis, Stage 2 spreads physically upward to the retroperitoneal lymph nodes, and Stage 3 represents distant metastasis. Here are the high-yield staging cutoffs you absolutely need to have memorized. For RCC, T1 is less than or equal to 7 centimeters and confined to the kidney. T3, and this is a major trap, means involvement of the renal vein, IVC, or perinephric tissues. T4 means it goes completely beyond Gerota's fascia. For bladder cancer, non-muscle invasive is TI, T1, or CIS. Muscle invasive is T2 and above. And for prostate cancer, localized disease gets surgery or radiotherapy. Metastatic disease gets androgen deprivation therapy with or without systemic treatment.
Section 6, Final Oncology Recalls.
Okay, lock in for this final rapid-fire blast. Every single one of these is a non-negotiable, highly testable one-liner. Ready? 1. Clear cell is the commonest RCC. 2. Smoking is a major risk factor for both RCC and bladder cancer. 3. Remember that RCC commonly invades the renal vein and IVC. 4. You see a left-sided varicocele, suspect RCC immediately. Moving to the bladder. 5. Painless hematuria is bladder cancer until proven otherwise. 6. Urothelial carcinoma is the most common bladder cancer. 7. Unless schistosomiasis is involved, that leads straight to squamous cell carcinoma.
Keep it moving, 0 omissions here. For the prostate, 8. Peripheral zone means prostate cancer. 9. Transition zone means BPH. 10. Do not forget that PSA is not purely diagnostic of prostate cancer. But 11. Osteoblastic bone metastases absolutely point to it. For testicles, 12. Radical inguinal orchidectomy is the standard treatment. 13. You must never perform a transscrotal biopsy. And 14. The golden rule one more time. AFP is never elevated in pure seminoma.
Finishing strong on pathways and cysts. 15. Para-aortic lymph nodes are the first spread for testicular tumors. 16. Inguinal lymph nodes are the first spread for penile cancer. 17. In pediatrics, Wilms tumor is the commonest renal malignancy. Finally, cementing those Bosniak cyst rules. 18. Classes I and II are benign. 19. IF demands follow-up. 20. Class 3 often requires surgery. And 21. Class 4 is highly likely malignant.
So, starting with Section 1, acute retention and torsion. These are two incredibly common and extremely time-sensitive ER presentations.
Let's walk through the exact step-by-step escalation of care for acute urinary retention, or AUR. Picture this patient in the ER. They are in a ton of pain. Step 1 is always assess ABCs and vitals and get them some adequate analgesia. Step 2 is immediate urethral catheterization using a Foley. Now, if that gets tricky, we move to Step 3, acute day catheter. But listen, that needs to be done by an experienced clinician. Step 4 is a big one. If you even suspect a urethral injury, or if the catheter just flat out fails, you go straight to a suprapubic cystotomy. And finally, Step 5, once they're drained, you have to monitor that urine output closely and watch out for post-obstructive diuresis.
So what happens next? Let's rapidly break down the workup. You're going to need a CBC, a urinalysis with or without a culture, and renal function tests with electrolytes. You will want an ultrasound KUB, but, and this is key, only after decompression. And here is a massive trap you have to avoid. Check the PSA only after the acute retention has entirely resolved. Do not check it during the acute phase. For definitive management, you're just targeting the root cause. If it's BPH, hit him with an alpha blocker or TERP. Urethral stricture, endoscopic treatment, or urethroplasty. Stones, obviously get definitive stone management, and a neurogenic bladder means clean intermittent catheterization. Now, when do we actually cut? The exact surgical indications are recurrent retention, recurrent UTIs, bladder stones, any renal impairment driven by the obstruction, recurrent gross hematuria from BPH, or just straight-up failure of medical therapy.
Let's shift gears to another massive emergency, testicular torsion. For ER management, it's ABCs and analgesia. Keep that patient NPO and get an immediate urology consult. But here's the golden rule. Write this down. Do not delay surgery for a Doppler ultrasound if your clinical suspicion is high. Under investigations, you have to remember that torsion is primarily a clinical diagnosis. You only, and I mean only, order that Doppler if uncertainty exists, and it absolutely will not delay the OR. Time is literally tissue here, guys.
So, definitive management. What actually happens in the OR? You're doing an emergency scrotal exploration, detorsion of the testicle, and then a bilateral orchidopexy. You have to secure both sides so this nightmare doesn't happen again. Now, if the testicle is completely non-viable, unfortunately, it's an orchidectomy. And what is the sole ultimate indication to rush to surgery? Any suspected torsion. Period.
All right, it's rapid fire time. Let's lock in these high-yield pearls for test day. For AOUR, BPH is the most common cause in older men. The very first step? Immediate bladder decompression. Never, ever force a urethral catheter. If you even suspect an injury, you must do a retrograde urethrogram or RUG before you even think about a catheter. And yet, rapid, complete bladder drainage is totally safe. Just keep an eye out for that post-obstructive diuresis. Okay, for torsion. The highest salvage rate is under 6 hours. An absent cremasteric reflex, that's your most reliable clinical sign. The classic presentation is a high-riding horizontal testes. Nausea and vomiting are super common. Remember, bilateral orchidopexy is always done, and say it with me, Doppler never delays surgery.
Awesome. Let's transition to Section 2, urethral and bladder injuries.
We're going to compare their initial ER management side by side because making the wrong move here can cause immense harm. For a suspected urethral injury, it's ABCs and standard trauma resuscitation, but you absolutely must avoid blind catheterization. Like, do not do it. If you need urinary diversion, you go with a suprapubic catheter. Contrast that with a bladder injury. Here, you still do ABCs, but you actually can place a Foley catheter, but only after you've firmly excluded a urethral injury. You'll also pump them with IV fluids and get them some analgesia.
Now, how do we investigate and manage these definitively? For urethral injuries, the investigation of choice, which is also the gold standard, is the retrograde urethrogram, the RUG. You'll probably also want a CT trauma protocol to hunt for associated injuries. Management scales with severity. Partial injuries just get catheter drainage, but complete disruption, that requires a delayed urethroplasty. On the flip side, for bladder injuries, your investigation of choice is a CT cystography, alongside a standard CT abdomen and pelvis. For management, location is literally everything. An intraperitoneal rupture means surgical repair. An extraperitoneal rupture? That can usually be managed with just catheter drainage, assuming it's uncomplicated.
And just to be crystal clear, here are the distinct indications for surgical intervention. You take a urethral injury to the OR if there's a complete disruption, if conservative treatment has failed, or if it's a highly complex injury. For the bladder, you operate on all 100% of intraperitoneal ruptures, plus any complicated extraperitoneal ruptures. Notice how the mechanism of injury practically hands you the diagnosis here. Let's rapid-fire these pearls. Urethral pearls. Blood at the meatus is the absolute hallmark sign. A high-riding prostate or a pelvic fracture screams posterior injury. A straddle injury? That points straight to an anterior injury. And again, never catheterize before a RUG when you suspect trauma. Bladder pearls. Pelvic fracture is the most common cause, and gross hematuria is the most common presentation. The bladder dome is the most frequent site of an intraperitoneal rupture. Your mantra here is intra equals surgery, extra equals catheter.
Moving right along, we're heading up to the upper urinary tract for Section 3, renal trauma management.
When a patient rolls in with renal trauma, you follow a very strict linear protocol. No skipping steps. Step 1. Always follow ATLS guidelines. Step 2. Assess their hemodynamic stability immediately, because this dictates literally everything else. Step 3. Push IV fluids or blood as needed. Step 4. Place a catheter if there's no contraindication. And Step 5. Continuously monitor that urine output like a hawk.
Now here's the most fascinating part. Hemodynamic stability is the boss. It completely dictates your definitive management pathways. For investigations, if the patient is stable, the investigation of choice is a contrast-enhanced CT with a delayed phase. You're also doing a fast scan, urinalysis, CBC, and checking renal function. Now for management. If they're stable, you go conservative. If they're stable but have an ongoing bleed, you opt for angioembolization. But if they're hemodynamically unstable, you are bypassing all of that and heading straight to surgery.
Specifically, your triggers for surgery in renal trauma are persistent instability, an expanding retroperitoneal hematoma, a renal pedicle avulsion, or persistent bleeding even after you've tried embolization. As for your high-yield pearls, remember that most blunt injuries are actually treated conservatively. Hemodynamic status is the ultimate decider. Delayed CT images are totally essential to catch a collecting system injury. And the golden rule of renal trauma, preserve that kidney whenever humanly possible.
All right, final stretch. Let's jump into Section 4, tackling severe urological infections, pyonephrosis and urosepsis. This is where minutes truly matter. I want you to really feel the ticking clock on this timeline. Instantly upon presentation, you're initiating ABCs, activating the sepsis protocol, pushing IV crystalloids, and drawing blood and urine cultures. Now, within exactly 1 hour, no delays, you must administer broad-spectrum IV antibiotics. Ongoing care is oxygen if they need it, vasopressors if they're fluid refractory, and absolutely, non-negotiably crucial, source control.
Now let's look at pyonephrosis. Basically, this is an obstructed, infected kidney. The ER steps are Step 1, ABCs and IV fluids. Step 2, cultures. Step 3, broad-spectrum IV antibiotics. But look at Step 4. This is the absolute lifesaver right here. Immediate urinary drainage. You cannot wait on this. Followed by Step 5, which is an urgent urology referral.
Notice the subtle differences in the workup for these overlapping conditions. For sepsis, you need a CBC, CRP, and crucially, serum lactate. You'll also get renal function, cultures, and a US or CT if you suspect an obstruction. For pyonephrosis, you also grab the CBC, CRP, renal function, and cultures, but pay attention to the imaging. The investigation of choice is an ultrasound KUB, while the gold standard, provided the patient is stable, is a non-contrast CT KUB.
How do we fix this definitively? If it's sepsis, your primary goal is to relieve that obstruction, start culture-guided antibiotics, and get them to the ICU if they hit septic shock. For pyonephrosis, definitive management means placing a DJ stent or a percutaneous nephrostomy tube, a PCN. You have to save the definitive stone treatment for later, after the infection resolves. You only move to outright surgery for pyonephrosis if you have failed drainage, a completely non-functioning kidney, or just extensive renal destruction.
Okay, one last round of high-yield pearls. Bring the energy for this. Sepsis. Source control is literally just as important as antibiotics. An obstructed, infected kidney is the commonest surgical cause. Never delay drainage, and an elevated lactate means poor tissue perfusion. For pyonephrosis, listen, it is a true urological emergency. Antibiotics alone are completely inadequate. The mantra is drain first, stone later. Any delay actively increases your patient's mortality.